All right, guys, this is chapter 21, the cardiovascular system function assessment and therapeutic measures. It's kind of a long one, so stick with me. If you have any questions, please let me know by email, group me in the classroom. That's all available to you. All right, so our learning outcomes are to identify the normal anatomy of the cardiovascular system, explain the normal function of the cardiovascular system, list data to collect when caring for a patient with a disorder of the cardiovascular system. Identify diagnostic tests commonly performed to diagnose disorders of the cardiovascular system. Plan nursing care for patients undergoing diagnostic tests for cardiovascular disorders. Describe current therapeutic measures for disorders of the cardiovascular system. Describe preoperative and postoperative care for patients undergoing cardiac surgery. All right, so in order to really understand cardiac disorders, it's really important for you to understand the pathophysiology and the blood flow through the heart. Let's just review that real quick. It's kind of hard to do without a whiteboard, but I will go over it tomorrow when we're in class again. So just real quick, blood that flows through the heart, it goes through the superior and inferior vena cava into the right atrium. Then it goes through the tricuspid valve into the right ventricle. Then it goes through the pulmonary valve, through the pulmonary vein, into the lungs, and it goes out the pulmonary artery into the left atrium of the heart, through the bicuspid valve. Remember, you try before you buy, and goes down into the left ventricle and out the aortic valve, through the aorta, and out to the body. Okay, so when there is a stenosis or a narrowing or a prolapsed valve or regurgitation or any of those things at different valves in the heart, it's really important to know where the blood flow is going to back into and which signs and symptoms to look for in regards to why the blood isn't being circulated appropriately. Does that make sense? So the heart in the mediastinum, it's in the middle of our chest, right? It has a pericardial sac, which is 3 layers, the fibrous pericardium, the parietal pericardium, the visceral pericardium, which is the epicardium. The epicardium is important because it helps keep it kind of lubricated. So there isn't a lot of, I guess, tension around the heart. When there's something wrong with the epicardium, you'll start hearing rubbing, and it can cause a lot of irritation because of the rubbing that's happening. So the epicardium kind of keeps the heart insulated and lubricated so it doesn't cause um, any damage to the rest around, any rubbing to the lungs and chest field, right? Then there's serous fluid between the layers. So here's the anterior heart view. Okay, pretty complicated, right? Um, Whenever we think of a heart, we think of it being sectioned off into 4 sections, the ones I just described. We have septums here and valves between the other 2 chambers. Here is your left atrium, right down here. This is going to be your ventricle. This is where blood is pushed through the aorta, right? There's the arch. So it's kind of complicated to see it from this area, and it kind of looks overwhelming, but just stick with me. We can simplify this. Here's a frontal view. This is a good place to see where blood flow goes. So this is the superior vena cava, and here's the inferior vena cava going into the atrium, the right atrium, going down to the right ventricle. Mind you, this is still deoxygenated blood. And when I mean deoxygenated, I mean it's already gone through the body. It still is sitting at like 98, 95%, okay? So, but it's used. It's used. It needs to be replenished, right? It's out of gas. So we go through the left pulmonary artery, Here, right here, is the semilunar valve, the pulmonary semilunar valve, and it goes into the lungs, comes out of the lungs, right? Where's the lung? Where is it coming out of the lungs? Here we go. Pulmonary veins into the left atrium and down. This is oxygenated now into the left ventricle, and then it's pumped through the aorta. Look at how it's pumped. It's kind of going against gravity too, right? So you can imagine if this was stenosed, how it might back up in with gravity, along with it being, narrowed. It can cause some pretty big issues. So there's four chambers: the right, the left atrium, the right, the left ventricle, the cardiac layers, the epicardium, myocardium, and endocardium. The coronary arteries. The coronary arteries is what actually feeds blood to the heart walls. So it's not the blood flow within the heart, it's the blood flow that actually feeds the heart. So when the coronary arteries are blocked, that's when our myocardial infarctions happen. Okay. Valves is the tricuspid, the pulmonary or the semilunar, and the mitral valve. So the mitral valve is also known as the bicuspid valve, and we try before we buy. So the tricuspid valve is between the right side of the heart, and the mitral valve, which is your bicuspid valve, is between the left side of your heart, between the atrium and ventricles. And then, of course, the aortic valve is the one that's opening to shunt blood out into the body. So it goes from, oh, here we go. We already just reviewed this, but we'll do it again. The vena cava to the right atrium, to the tricuspid valve, to the right ventricle, to the pulmonic valve, to the pulmonary artery, to the lungs, to the pulmonary veins, to the left atrium, to the mitral valve, to the left ventricle, and then the aortic valve, and then the aorta. All right, so cardiac conduction. Now, this is the electric conductivity of the heart. This is basically our pacemaker, right? The SA node is known as our pacemaker. And then you have your AV node. The lub and the dub are what you're hearing when you're listening for the SA and the AV node, okay? The bundle of His is what causes the contraction. It's electrical currents that run all the way down to our ventricles and make the contraction happen. There's the right and the left bundle branches, which control, of course, the left and right side of the ventricles. And then the Purkinje fibers, okay, that branch from the bundle of His. Here it is. All right. So the SA node is up by the right atrium. Okay. It's from its spots in the wall and right atrium, just below the opening of the superior vena cava. And an arterial bundle of conduction fibers rapidly conducts the impulses to the left atrium, and both atria begin to contract. So down here is the Purkinje fibers, and it conducts the impulses throughout the muscles of both the ventricles, causing them to contract almost simultaneously. Remember, the AV bundle soon branches into the right and left bundle branches. It's hard to see with my face in the way, so let me go ahead and do that. So this one initiates, the SA node initiates the contraction, and then the electric conductivity runs down the bundle of His through the branches and into the Purkinje fibers, causing first the contraction of the atrium and then the contraction of the ventricles. Now, most of the strength of the contraction is going to be down here in the Purkinje fibers and the bundle of His, because the contraction of the ventricles needs to be strong. It's pushing blood, especially the left ventricle, and that has the largest workload of the heart, is pushing blood out into the body. Cardiac output is the amount of blood ejected from the left ventricle in 1 minute. So stroke volume multiplied by the heart rate equals the cardiac output. Okay, so regulation of the heart. Remember the acceleratory center factors such as exercise and stress stimulate the acceleratory center, um, and it increases the heart rate. Why the inhibitory center factors such as rise in blood pressure stimulate the inhibitory center. The inhibitory center sends signals via the parasympathetic system. You guys, this is important to know because it's on your exam. The parasympathetic center is going to decrease it's an inhibitory response in the heart, okay? So the parasympathetic nervous system sends signals via the vagus nerve, which secretes acetylcholine to the SA and AV nodes, which slows the heart rate. Now, hormones and the heart. Epinephrine increases heart rate, forces of contraction, the cardiac output, the systolic blood pressure. Aldosterone regulates sodium and potassium. And atrial natriuretic peptide excretes sodium. Are you seeing something? Sodium, 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 potassium, they all take part in contractility of the heart. Our blood vessels are arteries, veins, and capillaries. Here's the structure of our blood vessels. Arteries have a large muscle. They have a lot more muscle because they have to pump. Whereas veins have less muscle but more valves. Valves that fill up and open up blood as they're kind of the aftermath of the pumping of the arteries. So as they go through the capillary walls to the arterioles and down. They go from the arteries to the arterioles to the capillaries to the veins, right? And then the veins pump deoxygenated blood. There's no rush. Arteries, there's a rush to oxygenate, right? But with veins, there's not as much of a rush to get it back up. That, for some reason, I don't know why. That's just why capillary edema occurs. As long as there's enough blood to oxygenate, there's not as much rush for venous return. But in any case, blood fills up the veins from gravity and pumps through the valves as they fill up. Now, sometimes these valves collapse and blood gets stuck in these areas, and that's varicose veins. That's how varicose veins occur. Collapse valves within the veins. All right, so our blood pressure is blood force against the blood vessel walls. Normal systolic is less than 120 and diastolic is less than 80. Renin, angiotensin, aldosterone mechanism. Okay, so the kidneys, listen to this. So when we have low blood pressure, remember I told you the kidneys, those dang kidneys, they are the prima donna of the body, right? So they get all up in airs when they feel like they're not getting enough blood. So they release renin, and it splits angiotensin and angiotensin 1. Angiotensin is produced in the liver, and angiotensin 1 is produced in the kidneys, and it goes down to make angiotensin 2. So here it is. The converting enzyme happens in the lungs. Anyhow, all this is there to increase blood pressure. Okay, that's the end result. So whenever we're doing things like giving ACE inhibitors, by the way, that's the angiotensin 1 inhibitor, right? Or this angiotensin converting enzyme. Whenever this is inhibited, then it decreases this process from happening. It's basically putting a muzzle on the kidneys, telling it to settle down, okay, you're fine. And that's one way we decrease blood pressure. Pathways of circulation is pulmonary and systemic. Okay, so aging in the cardiovascular system. The the conduction cells are less effective. Then usually patients have more atherosclerosis, meaning they have plaque on the walls of their arteries. Their resting blood pressure is increasing. Due to the plaque, the body has a higher demand because it takes more force to get through that narrowing of the plaque causing the atherosclerosis. They have a decreased heart rate, and the veins valves are incompetent, meaning more varicose veins, right? So we have dysrhythmias are more likely to occur, narrow vessels and lumens and rough surfaces are happening, left ventricle workload increases, left ventricle workload increases, strokes are more likely to occur, patients are more likely to suffer from fatigue and have venous stasis ulcers. So because of the atherosclerosis as well, patients have clot formation, decreased blood flow to the heart and other organs, and left-sided heart failure are likely to occur as well. So aging in the cardiovascular system due to atherosclerosis and arteriosclerosis, blood pressure increases, vein valves are more incompetent, heart muscle is less efficient, and arrhythmias are common. Number one cause of death is cardiovascular disease. So we try to counteract these effects by living a healthier lifestyle, no smoking, exercise regularly, decrease your fat in the diet, and normal blood pressure, glucose, and cholesterol levels, and normal weight are all going to help decrease your chances for cardiovascular disease. But remember, those are all things that we can help do. There are some things that you're just born with that you just can't alter. So Go Red for Women, American Heart Association movement celebrates power women have to band together to wipe out heart disease. Color red, red dress linked with its ability. Lovely. All right, so whenever we're doing a cardiovascular assessment, we do want to get a health history, including a history of your family and heart health because that is genetic. We want to do a physical assessment and we want to do diagnostic studies. What kind of diagnostic studies? Sometimes you can do a stress test. Sometimes we want to do labs that could coincide with heart, like a BNP or maybe troponins or things like that to just do regular. They're not really regular. If someone were to come in with signs and symptoms of an MI or things like that, we would do those. But maybe an EKG or an echocardiogram might be sufficient. Health history, we're going to use what's up, right? What's happening? How is it happening? Where, is there anything um, that makes it worse? Anything that makes it better? The same acronym that they use for pain is something that we're going to use for the symptoms of cardiac disorders as well. Allergies, past medical history, medications, family history, and health promotion methods. Your physical exam, what's the general appearance? What are the vital signs? Orthostatic blood pressure. If we're here to check, if we're here specifically for cardiac issues, not only are you going to want to get a blood pressure laying down, sitting up, and standing up, okay? Because they change significantly. But if it's too significant, then they could be suffering from orthostatic hypotension, and that could be really dangerous, okay? And of course, the height and weight. We want to inspect the skin and the color of the skin, and people who have cardiac issues tend to have colder extremities. Their lower extremities could be a different color. Sometimes they're like a purplish blue color. You'll see it a lot in the elderly, especially. Extremities in the hair, skin, nails, edema, color, jugular vein distension, cap refill, clubbing. Remember, clubbing is usually associated with oxygenation, and our heart and lungs work together to oxygenate. So put index fingers at the nail bed's first joint together. If there is a diamond shape in the space of the nail bed, this is normal. I don't know what that means. So I think it means whenever you're checking the cap refill, you're doing this, see, normal. Here we go. Clubbing early is at a 60 degrees. Clubbing severe is greater than 180 degrees. So, I guess that's the definition that defines clubbing. I seen clubbing earlier this weekend. I had a patient we had to send out for respiratory distress. He was a new patient. And when I was looking at his cap refill and he was in distress and I was getting his pulse ox, I noticed he had clubbing of his fingers. And I said, oh, he's got a pretty significant history of this. So it kind of told me a lot. Palpation is a point of maximum impulse. We don't, extremity temperature is poikilothermy, and edema, apply 5 seconds of pressure over a bony area of edema. Does indentation remain? If so, it is pitting edema. Pitting edema can be very common in right-sided heart failure because blood backs up into the body. Not quite as emergent as left-sided heart failure, but still nonetheless, the more fluid we have on board, the harder it is for the heart. So it's important that if somebody does have right-sided heart failure, we get them on diuretics to try to pull off the workload from the heart because of too much fluid. There we go. Pitting edema. And we judge the pitting edema by indentation. So if it's 1 to 3, like say it's like 3 millimeters in, like you could see your foot fingerprints just like that, that's like a 3+ pitting edema. If it's just slight and it goes away quickly, it's 2. If you could barely feel the lump over your fingers, it's 1. So auscultation, you want to hear the heart sounds, S1, S2, S3, S4. What you're listening to on all these is your electric conductivity, right? SA node. But you're also listening to where the valves. All right. So remember what I told you about the tricuspid, bicuspid, semilunar valve, and aortic valve. Okay. You want to listen for murmurs. Murmurs happen in valves. So what happens is there's a hole in the valve, and whenever water is that means that blood is shunting through when it shouldn't. It kind of sounds like a little bit of blood is going back into the place it's not supposed to be, the place it just got out of because of the force and the hole. And the smaller the hole, the louder the murmur. Okay? It's like you can hear water rushing through a smaller area versus a bigger hole. Would you hear it as clearly? No, you wouldn't. So it's kind of hard to explain, but I hope you understand. Knowing that a loud murmur is usually a good sign, and a murmur you can barely hear means the hole is bigger, and it's worse. It's a worse situation. Pericardial friction rub. It means the pericardial surface is rubbing together during the heartbeat, and that's usually a bad sign because the pericardial sac is what keeps us from having that friction rub. And if we hear that, that means something's wrong. It could be infected, it could be inflamed, something's going on. So here's the heart sounds, right? And remember I was telling you when you're listening to S1, S2, S3, S4, these are all the valves that you're trying to hear. Remember the tricuspid, the semilunar valve, the bicuspid, and then of course the aortic valve is your S2. Now, the diagnostic test that you'd want to use for non-invasiveness is arterial stiffness index, the blood pressure cuff computer map, and brachial BP waveforms. Identify atherosclerosis and cardiovascular disease. Chest radiography or a chest x-ray, a CT scan or an MRI, and an angiography. Electrocardiogram is also considered non-invasive. It records a cardiac electrical activity. It could be a 12, 15, or 18 lead. Um, Signal is average EKG is risk for ventricular arrhythmias. Ambulatory EKG monitoring is called a Holter monitoring device. You basically wear it all day long, and you keep it on, and you keep like a diary. And if you have like chest pain, or if you become severely out of breath, you want to push the button to say, hey, something's going on here with my heart, or you feel palpitations, or you feel something, and that will trigger for them to alarm and look and see what's going on. And you might also probably want to keep a diary of what's happening at that time as well. You could have gone through, gone up to go to the bathroom, or, stimulated a vagal nerve somehow, whatever. And it's important that you keep documentation of what's happening during that time. When somebody has a Holter monitoring device, you don't want them to get it wet. So you would instruct them to use a um, sponge bath during the time they have the Holter monitor on. The EKG uh, is, echocardiogram, excuse me, is an ultrasound. It records motion, heart structure, valves, heart size, shape, and position. There's a strain echocardiogram and a stress echocardiogram, and a transesophageal echocardiogram. Now, a transesophageal echocardiogram, they're going to use a throat numbing device. They're going to place a probe in the esophagus, which gives you a clearer image than an echocardiogram, as needed until the gag reflex returns. So what that means is you need to stay with the patient. We never want to leave somebody alone until the gag reflex returns, meaning they'll be in like a post-op situation until that gag reflex returns. Otherwise, if they eat something or drink something, they can aspirate, and they don't even realize what's going on. So it's best to stay with them until it returns. An exercise stress test is a cardiac stress test. It's a cardiac response to exercise and increased oxygen needs. They can do this chemically now. Like, for instance, for people who can't walk on a treadmill or run because of physical issues, they will give them the chemical that increases their heart rate and oxygen demand chemically. The problem is that has some effects as well. So be aware, they can become very dizzy, have heart palpitations, and issues with that as well. There's a peripheral vascular stress test, which the vascular response to walking. And this is kind of what it looks like. So other diagnostic tests that are considered non-invasive are your radial isotope imaging, radioisotope IV gamma camera scan, the cardiac ischemia damage perfusion. Okay, so it shows cardiac ischemia damage and perfusion. I don't know what any of those things are, but I do know that what it really consists of is it wants to, um, you would inject IV, and the IV would go to the areas of the damage, and then you could take a camera or a computer scan, and it will go to the areas of the damage so you could see how much of it is damaged. Like, for instance, if somebody had an MI and you wanted to see the extent of the damage that is necrotic, you would give an IV of the isotope, and it would go to the area. It's kind of tagged to go to those areas that are damaged in the heart, and you could see how big the necrotic tissue is. They use it a lot to see if like a dysrhythmia is going to be permanent or if it's going to be temporary. Usually done like 2 to 4 weeks follow up after an MI to see how much of the tissue got, oxygenated again or healed versus how much of it is damaged permanently. So a tilt table test is lying to standing blood pressure and heart rate. It's a diagnosis cause of syncope. So whenever I told you about orthostatic hypotension being pretty dangerous because people will be walking, getting out of bed and then they'll fall down because they'll pass out from lack of blood to the brain due to orthostatic hypotension. The Doppler ultrasound is impaired blood flow, reduces sound waves. So a Doppler, I know whenever you hear a Doppler, you think you're listening to a baby's heartbeat through the mom's belly, whatever. But we also use these Dopplers on feet and on legs to determine if a patient has a DVT. And that kind of tells us, oh, wow, there's no blood flow getting to the feet, and likely it's either an arterial block or a DVT. It's a really good thing that we use when we see a lot of swelling and redness on legs and feet, and that tells us, hey, we need to take a closer look, right? Being safe. Identify patients correctly. Use at least two ways to identify patients. For example, use the patient's name and date of birth. This is done to make sure that each patient gets the correct medicine and treatment. Blood studies. There's cardiac biomarkers like creatinines, kinase, troponins, and myoglobins. This is usually typically done whenever after chest pain or possible MI is happening. A C-reactive protein. Remember, a C-reactive protein only tests for inflammation, but inflammation will be happening if there's something going on with the heart. Homocysteines, lipid panels for triglycerides, cholesterol, and phospholipids, and a magnesium test. Improve staff communication, get important test results to the right staff person on time. Invasive studies like angiographies, cardiac catheterizations, hemodynamic monitoring, and electrophysiology studies. Now, a cardiac catheter is interesting because usually, I mean, a cardiac cath is done through the femoral artery, and it's like a little scope that goes all the way through, and it's checking the blood flow of the heart, and especially in the carotid arteries. So if we're looking at the carotid arteries, we want to see if there's any blockages. They can also put stents in while they're in there, and they can remove clots or scrape and do balloon angioplasties while they're in there. So they kind of are a diagnostic exam, and also they can do things to help treat the problem. The problem is you're putting a scope through a huge artery while the patient is still awake. The table's going to be turning a lot, so you better warn the patient because it's very discombobulating to be laying there and then to be turning the table on you while you're still awake. And it's just a good thing to teach them that they can move the table on you to get a better view of what they're looking for. Um, the other thing that you need to realize with uh, cardiac catheterizations, it's the recovery time from it. Remember, there's a pressure dressing often placed over the growing area. So if while it's still bleeding, um, a pressure dressing needs to be applied, but eventually it needs to be taken off so that blood flow can get back to the leg. That there has been some incidences where people have lost limbs because nurses are not being aware that they have to remove that, or more to the point that they didn't know that it was still there. Okay, so communication, thorough assessment are all really important after cardiac catheterizations. So therapeutic interventions, lifestyle and cardiac care, risk factors prevention like exercise, smoking cessation, healthy diet and weight loss, and support groups. We want to use anti-embolism devices like the stockings. Oh, Ted hose are really good things to wear. Intermittent pneumatic compressions are your SOCs and flow. What do we call them? Flotrons, where after surgery, especially because patients are at high risk for non-movement, we put them on to prevent DVTs. and of course oxygen. Uh-oh. Those were some typical medications used. Excuse me. Cardiac surgery is preparation for surgery. We're going to have a cardiopulmonary bypass. Um, there's going to be a video assisted thoracoscope and general procedure for cardiac surgeries. Minimally invasive cardiac surgeries are pretty much just your angioplasties. A bypass surgery is bypass graft surgeries are pretty extensive. Here's a bypass pump, right? So what's happening here is we need to work on the heart for a minute. So we need to stop. It needs to stop doing its job while we work on it. And they're going to clamp the aorta temporarily, and they're going to take the deoxygenated blood and bypass it through an oxygenator, heater, cooler, CO2 exchanger. Yes, we actually have one. They're going to roll it out to make sure there's no blood and no clumps in it or no clots. So a filter is going to be used and a bubble trap, so there's no air, and then it's going to go out into the aorta and oxygenate the body while they work on the heart. Pretty cool, huh? And here it is. Here's the cardiac pulmonary bypass pump in use. Kind of scary though. Like something is oxygenating your blood while they work on your heart. Okay, so what effects does epinephrine have on the heart? Select all that apply. Is it going to increase the heart rate? Yes. Is it going to slow cardiac conduction? No, I don't believe so. Strengthen the force of contraction? Yes. Remember, we're in fight or flight with epinephrine. We're going to increase cardiac output? Yes. We're going to increase systolic blood pressure? Yes. So we got 1, 3, 4, and 5, I believe. Yes. All right. The nurse plans care for an older adult based on what effects that occur with aging in the cardiovascular system. Select all that apply. Yes, arterial sclerosis happens in the elderly. Blood pressure increases, not decreases, so 2 is wrong. Vein valves are more competent? No, no. Heart muscles are less efficient? That is correct. And arrhythmias are common? Yes, so 1, 4, and 5. Okay. Which of these should the nurse inspect during data collection of the cardiovascular system? Select all that apply. So capillary refill, yes. Clubbing of the nail beds, yes. Nail bed color, yes. Jugular veins, yes. Pupil size, doesn't apply. Scalp and hair distribution, yes and no. I mean, hair doesn't grow where with poor circulation. So I don't know about number 6. So let's see. Nope, doesn't apply on this question. 1, 2, 3, and 4. After transesophageal echocardiogram, what check must the nurse perform for patient safety? All right, so remember they're going down the esophagus and they numb the gag reflex. So I would say number 2 is our answer. Yay! The nurse reviews lab values for a patient with chest pain. The nurse would maintain bed rest for a patient with elevation in which of these serum tests? Maintain bed. Okay, so elevation and CK kinase, yes. Yes, no, yes, no, yes. So I'm going to go with 1, 2, 4, and 6. Oh, not 2. Good to know.